Medication and prescriptions. This DVD looks at safe handling and administration of medicines in the care setting. There is a special section at the end which focuses on particular guidelines and requirements for domiciliary care workers. All health and social care settings are responsible for making sure that they have arrangements in place to assure the safe and effective management of medicines and for making sure that these systems are working effectively. Essential standards of quality and safety, published by the Care Quality Commission, require care providers to meet particular outcomes when delivering care to individuals. As somebody working in the health and social care sector, you need to know about these important standards, and your work practices must reflect them. If you are unsure or unaware of these standards, you will need to speak to your supervisor. Different types of medicines. Antibiotics, used to fight infection. Analgesics, used to relieve pain. Antihistamines, used to relieve allergy symptoms, for example hay fever. Antacids, used to relieve indigestion. Anticoagulants, used to prevent blood clotting, for example following a heart attack, thrombosis, or some surgical procedures. Psychotropic medicine, used to treat depression. Diuretics, used to get rid of excess fluids in the body. Laxatives, used to alleviate constipation. Hormones, for example insulin, steroids, hormone replacement therapy. Cytotoxic medicines, used to treat some forms of cancer. There are many over-the-counter remedies available in retail shops, chemists and health stores. Many are available by ordering on the internet and through newspaper advertisements. Homeopathic practitioners are available for anyone to consult, and medicines are supplied to treat a great number of ailments. Care should be taken to make sure that these remedies do not interfere with any other prescribed treatment. Different routes by which medicines can be administered. The following is a list of different ways in which medicines can be administered. Most of these routes can be administered by the service user if that's appropriate, or by a care worker. However, medication by intravenous drip is normally carried out by a trained person. Some service users treat their own diabetes by injecting themselves with insulin at the appropriate times. Each individual will have their own particular needs, which will determine whether they can manage their own medication, or would need and prefer someone else to assist them. Inhalation. Use of inhalers, nasal or oral. Injection, by piercing the skin. Ingestion, medicines, tablets taken orally, including under the tongue. Topical. Application of creams, lotions, and ointments. Infusion. Intravenous drips. Instillation. Administration of drops to ears, nose, and eyes. PR, per rectum, enemas, suppositories. PV, per vagina. Pessaries, creams. Classifications of medicine. General Sales List, GSL. These medicines can be purchased at retail outlets, such as pharmacies and supermarkets, without the supervision of a pharmacist. They are sometimes called over-the-counter medicines. These medicines are usually for treating minor complaints, which people do not feel serious enough to consult their GP or pharmacist about. Pharmacy only, P. May be purchased within a community pharmacy when a pharmacist supervises the sale. Prescription-only medicines, POM. These medicines can only be obtained by presenting a written prescription which has been signed by an authorized prescriber. Controlled drugs. There are three categories of controlled drugs: A, B, and C. Class A are treated in law as the most dangerous. Controlled drugs, CDs, are prescribed medicines that have additional safety precautions and requirements. For a current list of controlled drugs, log on to www.homeoffice.gov.uk. Legislation and guidance relating to medication. As a care worker, you will need to know about the laws and guidelines which control how medication is safely handled in your organisation. The list below will give you examples of some of the legislation and guidelines currently in use. New rules and regulations come into being sometimes, and new medicines also become available, so it is essential that you keep up to date with this. You are not expected to know the laws and guidelines in detail, but a good working knowledge of how they affect your daily practice is essential. Medicines Act 1968 and amendments. This Act is the most comprehensive legislation on medicines in the UK. The Act and its amendments provide much of the legal framework for the manufacture, licensing, prescription, supply and administration of medicines. Misuse of Drugs Act 1971. Controlled drugs and amendments. The purpose of this Act is to prevent the non-medical use of certain drugs. The Act controls medicinal drugs, which will also be included in the Medicines Act, and also controls drugs with no medical uses. Because of the dangers of misusing drugs, the penalties are severe. Drugs which are subject to this Act are called controlled drugs. Health and Safety at Work Act 1974. The Health and Safety at Work Act 1974 was introduced primarily to promote and improve health and safety at work. The Act is about people at work, and the main purpose of the legislation is as follows: to secure the health, safety and welfare of people at work, to protect others from risks arising from the activities of people at work, to control the use and storage of dangerous substances, to control the emission into the atmosphere of noxious or offensive substances. Essential standards of quality and safety. These regulations replace national minimum standards. The Care Quality Commission, CQC, has drawn up a set of standards relating to quality and safety. The standard relating to medication sets out what service users should experience. People who use services will have their medicines at the times they need them and in a safe way. Wherever possible, will have information about the medicine being prescribed made available to them or others acting on their behalf. This is because providers who comply with these regulations will handle medicines safely, securely and appropriately, ensure that medicines are being prescribed and given by people safely, follow published guidance about how to use medicines safely. We'll look at what these regulations mean in practice later in this resource. COSH Regulations 1999. You'll need to be able to understand the importance of the safe storage and disposal of substances harmful to health, and your employer will have a policy relating to this. Legislation relating to substances harmful to health are covered by regulations known as the Control of Substances Hazardous to Health Regulations, more commonly known as COSH. If your work in a care environment requires you to administer medicines, a COSH assessment must be undertaken on medicines which need to be handled. This could include such items as steroids or cytotoxic medicine. Protect you from personal risk and encourage you to follow safe practice. Policies and procedures. Every establishment involved in managing medication must have clear policies and procedures in place to protect both the service user and the care worker. You must be aware of and familiar with the policies in your own particular working environment. It is essential that you always work within these policies at all times. There must be policies on all aspects of medicine management in the particular care environment in which you work. These will cover areas such as obtaining and storing medicines, keeping accurate records, and administration. All of these areas will be covered in detail later. There must also be a policy in place to outline what action should be taken if medication has been taken in error. These policies and procedures have been drawn up to promote the safety and well-being of everyone involved in dealing with medication. Prescribing and dispensing medication. We buy over-the-counter remedies for ourselves from time to time, often keeping these to deal with headaches or colds and flu, and also ointments and creams to treat minor ailments. These medicines are the ones freely available for everyone to buy without prescription. If you buy headache remedies from a supermarket, you will be unable to purchase more than 32 at a time. But if purchased from a pharmacist, this can be different. In some circumstances, medicines are prescribed for us by a suitably trained person. Here are some examples of people who can write a prescription. General practitioners, GPs. Dentists. Some nurse practitioners who have qualified as prescribers, for example district nurses, health visitors and midwives. Physiotherapists, chiropodists, and radiographers can also qualify to prescribe. The above list is not comprehensive, but gives examples of how government policy is to widen the range of people who are permitted to prescribe, so that easier access to treatment is available for service users in a variety of different circumstances. Once the medication has been prescribed, it will be dispensed by a pharmacist, and arrangements will be made to get the dispensed medicine to the service user. In the home care environment, the home carer or relative may collect the medicine from the local pharmacy. In residential settings, medicines will be delivered. Where medicines are being received for several service users within the same establishment, various staff members may be involved. The manager should have overall responsibility. Office staff may be involved in the clerical management of receipts of medicines. A patient information leaflet, PIL, must be supplied with each medicine. These leaflets should be available to the service user also. Receipt of medicines. People may need to transfer from one care setting to another, for example, hospital admission, respite care, or permanent move to a care home. It is essential that the individual's medication is sent with them, and this will ensure continuity of care. When care workers are responsible for giving medicines to the person, a copy of the record of administration is essential. This will state which medicines have been taken regularly, and if the individual refuses to take any. This information is very important for the new care setting. When a person is transferred to another care setting, you should make a record of the medicines that were sent with them. The following information should be recorded: date of transfer, name and strength of medicine, quantity, signature of the member of staff who arranges the transfer of the medicines. All medicines brought into a care environment must be recorded. This will include medicines on discharge from hospital, brought from another care environment, and service users' own homes. The records must show the following: date of receipt, name, dosage and strength of medication, how much has been received, the individual for whom the medication has been prescribed or purchased, the signature of the person receiving the medication. When an individual is discharged from hospital, they should have with them documentation listing all their current medication. It should be carefully noted that this medication could be different from the medication they had when they were admitted to hospital. The new list must be compared with the old. If there are changes, the pharmacist should be informed. A new medication administration record, MAR, should be prepared, and any unwanted drugs should be disposed of. A new prescription should be requested as soon as possible. Obtaining supplies of medication. You may need to request a repeat prescription from the GP surgery or through the pharmacy's collection service. You should know how your local GP surgery processes such requests. It may take several days to process, so you need to make sure that you plan this carefully so that the individual does not run out of medication. A list of medication which will be required on an ongoing basis will be given to the service user in the form of a computerized record. As medication is required, this record is submitted for processing so that further supplies can be obtained. Obtaining acute medicines. On occasions, a prescription is written for a medicine that the person has not used before or does not take regularly. This would not generally be listed on the repeat prescription document. It's obtained as and when it's needed, and your work setting must have a separate procedure to access these medicines as quickly as possible. Storage. Requirements for storage of medication will vary in different settings. If you are assisting someone in their own home, they will need to decide how and where to store their medication. No special cupboards are required in a domiciliary setting. The medication is the property of the individual for whom it was prescribed. Care workers must not use any medication that has been prescribed for a service user for themselves, not even a headache pill. In care homes, controlled drugs must be stored in cupboards that meet the requirements of the Misuse of Drugs Safe Custody Regulations 1973. Unless the service user is looking after their own drugs personally. Only people who have been authorized should be able to access the cupboard. The keys for the medicine cupboard should not be part of the master set. In order to maintain the security of the medicines, there must be limited access for authorized members of staff only. There must be a procedure for the handling of the keys in terms of where they are kept, who has access to them, and what to do if they go missing. If an individual wishes to look after their own medicines in a care home, they can have their own personal lockable cupboard or drawer. Medicine storage cupboards should not be used for storing anything else. Refrigerated storage. Some medicines must be stored in a refrigerator because at room temperature they go off. The information supplied with the medication will state if it should be kept in a fridge. In a care home, there should be a separate and secure fridge for this purpose. The temperature should be monitored daily and should be within the range of 2 and 8 degrees Celsius. If you are supporting someone in their own home, a separate fridge is not a requirement. However, you should check regularly that the fridge is working correctly and set at the correct temperature. There may be other storage considerations to take into account. Is there adequate and appropriate storage for nutritional supplements, prescribed dressings, and continence appliances? Medical products should not be stored on the floor. Disposal. All care settings should have a written policy for the safe disposal of surplus, unwanted, or expired medicines. If you are responsible for the disposal, you must ensure a complete record of medicines is made. The medication stored within a care setting should be relevant to the current needs of the service users. Unused or out-of-date medication should not be stored. When someone leaves the care setting, the medication should go with them. And also, when there has been a change in medication for an individual, the unused product should be disposed of. Other situations where medicines might need to be disposed of could include when a person dies or the medicine reaches its expiry date. The record of disposal should include name and strength of medication, quantity removed, date of disposal, service user's name, signature of person arranging disposal. The usual way to dispose of unwanted medication is to return it to the supplier for safe disposal. Everything that is returned to the pharmacy must be disposed of, even if it is unopened containers. The products cannot and must not be reused for other individuals. Care homes or nursing homes must not return medicines to the community pharmacy or surgery, but must use a licensed waste management company. Safe administration of medicine. Care workers may, with the consent of the resident, administer prescribed medication so long as this is in accordance with the prescriber's directions. The Medicines Act 1968. The person may at any time refuse to take medication that the care worker offers. In care homes, care workers must be trained before administering any medication to service users. This should cover the following: creams and ointments, capsules and tablets, drops for eye, ear or nose, inhalers, measured liquids, for example lactulose, patches. In care homes, medicines requiring specialized techniques are usually administered by a community nurse who visits the home. There are situations where some care home staff can use specialized techniques, but this will depend on assessment of competence and insurance cover. No care worker should assume they can administer medicines in this way. Care workers should refuse to assist if they do not feel competent. In nursing homes, there will be qualified nurses who can use specialized techniques if they are trained in current practice and competent. Specialized techniques could include rectal administration, for example suppositories or diazepam, percutaneous endoscopic gastrostomy, PEG, insulin injections, oxygen. Medication is administered to service users in a wide variety of care contexts. Your own role in your work setting must be clearly understood. This will differ from one type of care setting to another. For example, if you are working in a care home, your role in handling medication will be different to that of someone working in an individual's own home. It is important to establish the difference between assessing an individual to take their medicine and administering the medicine to them. When a care worker assists someone, the service user must indicate what actions they must take on each occasion. If the service user is unable to do this, the activity is interpreted as administering medicine. Consent. Every individual has the right to refuse medication. Should this happen, as a care worker, you must record the reason for that refusal. There may be circumstances where an individual is not able to give consent to treatment, and the advice of the general medical practitioner who is responsible for the treatment should be sought. If a person lacks the capacity to make a decision about taking medication, the principles of the following acts must be applied. The Mental Capacity Act is a law that affects people of 16 and over who live in England and Wales. In Scotland, it is the Adults with Incapacity Scotland Act 2000. In Northern Ireland, the mental capacity legislation is currently under review. The Act sets out safeguards to empower and protect a person who is assessed as not having mental capacity. What is the definition of mental capacity or lack of? If a person has mental capacity, it is believed they have the ability to make decisions. In order for a person to have that capacity, they must meet the following criteria laid down by the Mental Capacity Act. Understand the information given to them. Retain that information long enough to make that decision. Use the information that is available to make the decision. Communicate their decision by the appropriate means. It could be talking, blinking, using sign language, or any suitable means of communication. The Mental Capacity Act makes it clear that any assessment of a person's capacity must be decision-specific, and this means that an assessment of capacity must be about the particular decision that has to be made at a particular time, and is not about a range of decisions. If someone cannot make complex decisions, this does not mean they cannot make simple decisions. You cannot decide that someone lacks capacity based on their appearance, behaviour, age or condition. Those people lacking capacity could include people with a learning disability, a brain injury, dementia, a mental health problem, or a stroke. The mental capacity may be permanent or temporary. For full details of how these acts apply to your work setting, enter Mental Capacity Act into your computer's search engine. Medication should not be given covertly. For example, putting medication in an individual's food. However, there may be circumstances when an individual's refusal to take medication could result in essential treatment being missed. In these circumstances, a multi-professional team, including care workers and relatives, where possible, of the individual, must undertake the decision. Any such decision must be recorded in the individual's care plan with a date for reviewing the decision. There should be a written policy covering these situations. Sometimes an individual may refuse medication because it's in the form of tablets which are difficult to swallow. In such circumstances, perhaps an alternative form of the medicine may be more acceptable. Advice on these matters should be sought from the pharmacist. Safe practice is to take the medicine directly from the container in which it was dispensed. It's important that the service user's privacy and dignity are maintained, especially when medication is administered by an invasive route, for example, suppositories. Equality and diversity issues. Service users will have different preferences, and these may relate to equality and diversity. For example, vegetarians and people from some religious groups may not want gelatin capsules, which are made from animal fat. Some people may prefer to have medicines given to them by someone of the same sex. Some religious festivals include fasting, and some people may prefer not to have medicines given at certain times. Risk assessment. When care workers are required to administer medicines, a COSH assessment should be carried out on the medicines which are to be handled. Some examples of this type of medication could be external applications of creams and medicines. The risk assessment should be a means of minimizing any risk to care staff whilst undertaking their work. In many situations, individuals will be responsible for taking their own medicines, and the essential standards of quality and safety place emphasis on the positive aspects of this. By being responsible for their own medication, individuals will maintain a sense of independence and will be prepared for any possible discharge from the care situation. It is worth noting that medicines prescribed for an individual become that person's property. This principle applies also to dressings, surgical sundries, and nutritional supplements. Procedure for giving medicines. Preparation. Before administering a medicine to an individual, you need to do some preparation. Make sure that you have checked some basic hygiene factors which will help prevent any possible spread of infection. Here are some examples. Make sure that you have washed your hands thoroughly. Use disposable gloves and aprons where appropriate. Make sure any cuts or sores are covered with impermeable dressings. Deal with sharps, spillages of body fluids, according to the policy and procedures of your working environment. As well as checking hygiene procedures, you should also have all the necessary recording documentation to hand so that an accurate record is kept of medicines administered. The Medicines Act clearly defines that medicines must only be administered to the person for whom they have been prescribed, labelled and supplied. Medicines must only be given from the container they were supplied in. They should not be put in advance into medicine pots, as this is secondary dispensing and can lead to accidental errors. The medicine must have a printed label containing the following information: service user's name, date of dispensing, name and strength of the medicine, dose and frequency. If the medicine is in a container within another container, each part must be labelled. If the label becomes detached from a container, then advice must be sought. Labels should never be altered. Your workplace will have a procedure for the safe administration of medicine. It should cover both prescribed and over-the-counter remedies. Ensuring correct medication. Checking. the identity of the individual to whom the medication is being administered, the name of the medication and dosage, the medication administration record, MAR, the route for administration of the medicine, any special instructions such as after food, the environment is suitable, equipment, side effects and adverse reactions. Side effects are unwanted but natural and anticipated consequences of taking a particular medication. They can be minor and of little consequence, or be serious and require attention. Adverse reactions are completely different. They are rare and unforeseen negative bodily responses. Some examples of common symptoms of adverse reactions may be rashes, breathing difficulties, swellings, nausea, vomiting, diarrhea, stiffness, shaking, headaches, drowsiness. It is important that you record any adverse drug reaction or suspected reaction to your manager immediately. The service user's doctor or pharmacist should be notified and consulted before any more of the medication is given. Some service users will wish to use remedies which can be bought over the counter at a chemist or other retail outlet. Sometimes an individual may be a firm believer in complementary medicines or homeopathic remedies. Whilst individual choice should be encouraged, it is important that checks are made to ensure that any of these substances do not cause problems when taken alongside any medication which has been prescribed by a medical practitioner. Remember, you can get advice from your local pharmacist. Record keeping and audit. Record keeping is a vital part of the safe administration of medicine. The records will provide an accurate record of medicines administered to service users, when they were administered and by whom. This is called an audit trail. These records are to protect both the service user and the carer. Once again, there will be a procedure for you to follow when keeping records. You must record the medication given, to whom the medication is given, the time it is given, the dosage given, the method of administration, comments and signature after each administration. There are different types of recording documentation available, but the manager will provide and train you in the use of the records kept in your care setting. A document that records medication is sometimes called a Medicine Administration Record, MAR. This record will include all prescribed medicines being administered to the service user. Ideally, it should include other non-prescription medicines as well. The care establishment must keep an up-to-date and accurate record of current medication prescribed for each service user. This document will show what date medicines were given and will be signed by the person giving the medicine. It should also be recorded when the service user refuses to take the medication which has been prescribed and the reason why. These records should be retained for a minimum of 3 years, even when the service user has left. Every care establishment should have a list of staff who are responsible for administering medicines. There must also be a procedure to follow if there is any error identified in the administration of medicine. Self-administration. A service user who is administering their medication themselves does not have to complete a medicine administration record. However, a record should be kept of the medicines given to such a user, including the date and signature of the responsible carer. Audit trail. There must be a clear audit trail of medication prescribed, received, administered and disposed of. The documentation within the establishment should show clearly what should be in the medicine storage facilities. Regular audits to check for accuracy should be built into the routine of the establishment. These storage records can be cross-referenced to each service user's medication record, which would show number of doses received, administered and remaining. If an audit shows up anything unusual, a report must be made immediately to your manager. Training. Care workers must be appropriately trained in the handling and use of medication, and have their competence assessed regularly. All staff training should be documented for each care worker. Induction training. Care workers who are new to care work should not be allowed to give medicines until they have been trained to safely do so. If asked by a service user to give some treatments, the request must be transferred to a senior colleague. Care workers transferring from another care setting must be assessed for competence before being allowed to give medication. There is now a section which focuses on domiciliary care. The essential standards of quality and safety apply to domiciliary care settings as well. Care staff must also follow their employer's policy and procedures in relation to the administration of medicines. It is important to establish the difference between assisting an individual to take their medicine and administering the medicine to them. When a care worker assists someone, the service user must indicate what actions they must take on each occasion. If the service user is unable to do this, the activity is interpreted as administering medicine. There are, however, some other general rules when supporting adult service users. Adults supported in their own homes by a domiciliary care worker will normally be responsible for their own medicines, both prescribed and non-prescribed. Some individuals will be able to administer their own medicines, but others will need some support. This support is generally classified into 3 levels, which we will look at in more detail later. As stated earlier, care workers may administer prescribed medication to another person with their consent in accordance with the Medicines Act 1968. You should not offer advice to people about prescribed medicines, over-the-counter medication, or complementary treatments. You should not mix medicine with food or drink if the intention is to deceive someone who does not want to take the medicine. This is called covert administration. If an individual is unable to consent to treatment because they lack capacity, the individual's doctor must make the decision to give medicine covertly only if it is in the best interests of the individual. This must be clearly documented and regularly reviewed. If an individual has difficulty swallowing, it may be necessary to crush tablets if there is no liquid alternative. This must only be done with the approval of the prescriber or pharmacist, as some medicines must not be crushed or dissolved in water. Let's look at the different levels of support which may be given to a service user. General support, assisting with medicine. This type of support is given when the individual takes responsibility for their own medication, and particularly in situations where they contract their support through direct payments. General support needs should be identified at the care assessment stage and recorded in the individual's care plan. The support given may include some or all of the following: requesting repeat prescriptions from the GP, collecting medicines from the pharmacy or dispensing GP surgery, disposing of unwanted medicines safely by returning them to the supplying pharmacy when requested by the individual. An occasional reminder from a care worker to an adult to take their medicines. If the individual constantly need reminding, this may indicate that their care plan should be reviewed to determine whether full support is needed, and you should speak to your manager or supervisor about this. Helping with assessing containers, for example opening a medication bottle or getting tablets out of a blister pack. You should not be asked or expected to select the medication. Administering medication in accordance with the MAR chart. This level identifies that the service user is unable to take responsibility for their medicines. This may be due to impaired cognitive function or physical disability. The need for medication to be administered by a domiciliary care worker should be identified at the care assessment stage and recorded in the individual's care plan. If an individual has given consent to medication being administered, this must be recorded in the care plan prior to the medication being administered. If an individual is unable to communicate their informed consent, the prescriber, For example, the GP must confirm formally, for instance by letter or email, that the treatment is in the best interests of the individual. Administration of medication may include some or all of the following: selecting and preparing medicines for immediate administration, including selecting from a monitored dosage system or compliance aid without direction from the service user. Selecting and measuring a dose of liquid medication for the individual to take. Applying a medicated cream or ointment. Inserting drops into ear, nose or eye. And administering inhaled medication. Putting out medication for the person to take themselves at a later time to enable their independence. Reminding the individual to take their medication on a daily basis. You should only help individuals with their medication if you are competent and confident. If you do not feel confident, you should refuse to carry out this task until you have received further suitable training. It is important that you only give medication taken from the original container. The container has been dispensed and labelled by a pharmacist. You must be aware of the possibility that individuals may be discharged from hospital with different medication from that retained in their home before they were admitted. If in doubt, you should seek advice from your manager. Administering medication by specialised techniques. In exceptional circumstances, and following an assessment by a registered healthcare professional, a domiciliary care worker may be asked to administer medication by a specialist technique, including rectal administration, for example suppositories, insulin by injection, percutaneous endoscopic gastrostomy, PEG, nebulized therapy, oxygen therapy. This level of support requires specialist training by the named registered healthcare professional for this individual. Ongoing competence must be monitored and assessed. This task cannot be delegated by one care worker to another. If you are asked to do this by either another care worker or the service user, you must speak to your manager or supervisor. The task is also specific to the individual, which means that the care worker can only carry out this level of support for a named service user. Care workers should be able to refuse to carry out this type of support if they do not feel confident and competent. Training for domiciliary care workers. Domiciliary care staff must be trained to at least the same standard for care workers in a care home, not only because people in a domiciliary care setting are more vulnerable, but because care workers are working alone. You must have training that will meet the needs of the service users. This training should include how to prepare the correct dose of medication, how to administer medication, including tablets, capsules and liquid medicines given by mouth, ear, eye and nasal drops, inhalers and external applications and patches. How to ensure that medicines are only administered to the service user for whom they are prescribed, given in the correct prescribed dose, and at the correct time by the correct method or route. Checking that the medication used by date has not expired. Checking that the person has not already been given the medication by anyone else, including a relative or care worker from another agency. This means checking the MAR chart. How to recognize and report side effects, reporting refusals and errors. How to administer and record medicines prescribed as required. For example, painkillers and laxatives. How to deal with situations when people request non-prescribed medicines. Record keeping, following infection control practices. It is the responsibility of your employer to assess whether you are competent in medication administration before being given such a task. Your employer should have clear medicine policies and operating procedures for you to follow. You may now wish to complete the questionnaire.